So we're going to switch to the next talk. It's a pre-recorded talk given by Dr. Jason Luke, who is a member of the Melanoma program and also director of the Cancer Immunotherapy Center at the Hillman Cancer Center.
Hello, I'm Jason Luke from UPMC Hillman Cancer Center in Pittsburgh. I'd like to thank the organizers of the meeting for the opportunity to speak with all of you today. I'm going to be speaking on the development of new immunotherapies for melanoma. The title of my lecture today is The Future of Metastatic Melanoma Treatment. And so just to level set for everyone in the audience, melanoma therapy is really split into two categories at the current time. The first is using BRAF-directed therapies, which is outlined on the left-hand side, where you can see that normal cells have a growth pathway dependent on sort of getting food. We call it a ligand that drives signaling through these different proteins. But we know that in melanoma, approximately half of melanomas have a mutation in a gene called BRAF, most commonly V600E, that turns this pathway on all the time, even when the food is not around. And so because of that, developing drugs to block BRAF or MEK have been standard treatments in melanoma and very effective. By contrast, we use immune checkpoint blocking immunotherapy as well, with drugs like ipilimumab, which blocks the molecule CTLA4. And that's a protein that regulates the on switch, so to say, for immune cells. Another immune checkpoint is the PD-1 or PD-L1 axis. And by blocking this, we can wake up immune cells that have come to fight the cancer, but been put to sleep. So a number of different immune therapies are coming forward and likely to change the standard treatment for melanoma in the next few years. And the most urgent of these, or the most recent of these, is going to be that of LAG-3. So LAG-3 is another protein on immune cells that are what we call dysfunctional, meaning they've come to find the cancer, but they haven't been able to kill the cancer. And a clinical trial has been performed and results are in now for combining a LAG-3 antibody called relatlimab with nivolumab in patients with melanoma, showing a superior outcomes compared to those patients who got nivolumab alone. And this new treatment, relatlimab, is going to be reviewed by the FDA and we assume approved near the end of March in 2022. Another new kind of treatment that's coming forward and that we've had a big impact on at the University of Pittsburgh has been the development of this molecule called Vidutolamod. And who comes up with these things, right? Well, this is a very interesting drug that has an immune stimulant called a toll-like receptor 9 agonist wrapped in the particles of a virus. And we call this a virus-like particle. And the reason this matters is that the virus-like particle is noticed by the immune cells and taken up into immune cells because they think it looks like a virus. But upon doing that, the immune stimulant is released, which can actually drive immune responses to be enhanced by other immunotherapies to fight melanoma. And in a group of patients who had already had standard therapies, giving this drug alone or with pembrolizumab showed that about a fourth of all the patients would have their tumors shrink. And this treatment was generally speaking safe, with only some low-grade flu-like symptoms upon injection into the tumor. Another therapy to be aware of is a new version of an old therapy in melanoma. So historically, we gave a treatment called interleukin-2 that could drive some patients' immune systems to get rid of melanoma, but caused a lot of side effects. And so a new kind of IL-2 molecule is this molecule, and it has a great name. It's called Benpegol. And the drug preferentially tries to turn on the good parts of IL-2 and leave aside the bad parts. And the drug has been designed so that it releases this molecule slowly over time to stimulate immune cells of various kinds to drive responses against cancer. And on the right-hand side, you see what's called a waterfall plot showing each patient's tumor and how much it shrank. you'll notice this minus 100%. So almost 40% of patients in this trial of Benpeg plus nivolumab had complete response or eradication of their cancer. And this is very exciting. A phase 3 clinical trial is already completed, and we're awaiting the results for this clinical trial any minute, actually. A further therapy to be aware of is combining different kinds of cancer treatments. And so a category of blood vessel blocker drugs has been around for a long time in cancer. And more recently in melanoma, we have found that combining them with immunotherapy with PD-1 antibodies might be successful. And the reason for this is getting rid of abnormal blood vessels allows immune cells, CD8, to come into the tumor. And it turns out these drugs have other effects on other immune populations, which also can be enhanced by drugs like pembrolizumab. And again, in a cohort of patients who had previously received standard drugs like Nivo, Pembro, and Ipi, we saw that treatment response could be observed in 20 to 30% of those patients, which is really promising given that this is an early phase clinical trial. And so we'll shift gears slightly now. Those were all treatments that were being developed for patients who had never had a treatment before. What about those patients where the treatment has stopped working? Well, one approach is to try to deliver really powerful immune molecules called cytokines into the tumor. And so one of them is interleukin 12. And interleukin 12 can drive a lot of immune effects that can be augmented for immunotherapy. And this is a little bit of a complicated drug. It has a great name called tavokinogene telesplasmid, and it is literally injected into the tumor, followed by a slight electrical signal, and then combined with immunotherapy like pembrolizumab. And what you can see is this can lead to regression of tumors and this huge, sort of burst of immune activity after delivery of this drug. And a phase 3 clinical trial is looking at this combination now. There's been a lot of interest in our field about harnessing patients' own immune cells to fight their cancer, something called autologous tumor-infiltrating lymphocytes. And here, the patient comes in for a surgery where the melanoma is removed. We take the immune cells out and grow them in the lab. Then we bring the patient back and give them back their own immune cells. And in clinical trials, this has also been shown to drive long-term immune responses that lead to disease shrinkage in some patients. And again, we expect this to be approved by the FDA in the coming year. The final one to be aware of is a breakthrough in immune engineering using T cell receptors, or the recognition switch on immune cells. And this drug called tebentafusp is an ImmTAC molecule with 2 parts: a targeting domain with the T cell receptor that recognizes an melanoma molecule called GP100, and connected to another part called an effector domain, which binds to immune cells. So this literally pulls immune cells into the cancer. And that can lead to very improved immune responses, and actually has led to the improvement in survival of patients with uveal melanoma, a rare subset of melanoma in the eye, which metastases to the liver. And this is the first drug ever developed just for that subset of melanoma. So in conclusion, combination therapy is clearly the future of melanoma and probably all cancers. There are many novel immunotherapy approaches that are being developed, including all those that I covered today. And I hope you found that useful and interesting. Thank you very much for your attention.
I just want to update. So this was registered, a pre-recorded talk by Jason Luke. He talked about many combination. And what we have heard since he recorded that effectively the combination PD-1 and LAG-3 is approved. So it becomes approved as a frontline therapy for advanced melanoma. So now you can be treated with this. It's FDA approved. This is the good news. On the bad side, he talked also about this Benpeg IL-2-like molecule that was tested in a large phase 3 in combination with Nivo as compared to Nivo alone. And this has failed. So you're not going to be treated with this combination as a first-line treatment. So we still don't understand the consequences of that. Much work remains to be done in this area of IL-2 type treatment of melanoma.